And welcome everyone. I'm Dr. Dwight Herron, the chair of the Government Relations and Economics Committee. I'd like to welcome you all to this ACRO-sponsored webinar with CMMI specifically focused on the radiation oncology model. First, I'd like to thank each of you for your efforts in patient care and working closely with the college and our efforts as we work with CMS and other government agencies in an effort to deliver the best possible care for our patients. We are quite fortunate to have Mrs. Marcy O'Reilly, who's generously given some of her time this evening after certainly a long day to talk to us about the radiation oncology model. Marcy has been a really important collaborator of ours in terms of discussions we've had in the past over the years, not only about the radiation oncology model, but a variety of important CMS initiatives. And we're really fortunate, and we want to thank Marcy for taking the effort to talk to us about the radiation oncology model. 8 p.m. This evening. As you know, that model will commence in January of 2022. And we've fielded, and I know CMS has hosted a number of these webinars over the last year or so. And our membership has clearly indicated an interest in asking and getting some clarification. And so we appreciate Marcy coming on this evening to talk with us. We're first going to start with a slide presentation from Marcy, and then we'll lead into some of your own questions. We have some pre-submitted questions that we'll answer, and you do have an opportunity to submit questions live. Would encourage you to use the chat box for that feature. We'll try to get to as many of those questions as possible. If there are questions that we don't get to this evening, we'll certainly make every effort to get those questions answered and post them on the member section of our webpage. So with that, I'll turn it over to Marcy. Again, thank you so much for dedicating some time this evening to talk to our membership, and welcome. Marcy.
Thanks, Dr. Herron, and good evening, everyone, and thanks for inviting me to participate. I'm always happy to do so. Let me just get my screens all organized here. Next slide. Sorry, my slides, so my notes, there we go. So this slide that you're seeing right now contains a lot of history of the genesis of the radiation oncology model. But most recently, in September of 2020, the Center for Medicare and Medicaid Innovation published a final rule that established the RO model with a start date of January 1 of 2021. As a result of the ongoing COVID-19 public health emergency, CMS included an interim final rule with comment period in the calendar year 2021 OPPS and ambulatory surgery center payment system final rule to delay the start of the model until July of 2021. Subsequently, the 2021 Consolidated Appropriations Act included a provision that prohibits the implementation of the RO model prior to January 1, 2022. And in the current proposed rule for the OPPS and ambulatory surgical center payment system rule, we are making proposals to address the necessary changes as a result of this delay and some additional proposed modifications to the RO model. Next slide. So for those of you, many of you on the call, I'm sure have been versed in the model for a while, but in case there's some new folks, I just wanted to give a high-level overview of the model. So in review, the radiation oncology model will test whether making site-neutral, modality-agnostic, prospective episode-based payments to hospital outpatient departments and physician group practices, including freestanding radiation therapy centers, for 90-day episodes of radiotherapy will preserve or enhance the quality of care furnished to Medicare beneficiaries while reducing or maintaining Medicare spending. The model is designed to encourage uptake of evidence-based care, remove the differences in payment across different care settings, and address historical instability in payment rates. The RO model requires participation from radiotherapy providers and suppliers that furnish RT services within randomly selective core-based statistical areas, or we refer to CBSAs, that represent 30% of RT episodes nationally. Next, wait a minute. Okay, the next slide, please. There we go. Here's this slide. This slide and the next slide contains information included in the current proposed rule, but we have proposed to begin the RO model on January 1, 2022 with a 5-year model performance period ending December 31st, 2026. We proposed to change the baseline period from 2016 through 2018 to 2017 through 2019. And we are proposing to lower the discounts on professional component payments to 3.5% and to 4.5% for the technical component payments. Additionally, we're proposing to remove brachytherapy from the list of included modalities on the RO model so that it would continue to be paid fee for service. In light of the current public health emergency and several recent natural disasters, we are proposing to adopt an extreme and uncontrollable circumstances policy. This policy would provide flexibility to reduce the administrative burden of model participation, including reporting requirements and or adjusting some of the payment methodology. We are proposing to exclude hospital outpatient departments participating in the community transformation track of the new Community Health Access and Rural Transformation Model, also known as the CHART model, from participating in the RO model. For the CHART model's ACO transformation track, we would follow the same policy for overlap between the RO model and the Medicare Shared Savings Program ACOs. And we are proposing to modify our overlap policy such that only hospital outpatient departments that are participating in the Pennsylvania Rural Health Model would be excluded from the model rather than all hospital outpatient departments that are eligible to participate in the model. Next slide. The two items on this slide are not proposals per se, but just clarifications that we made in the model. We're removing liver cancer from the RO model because the treatment of liver cancer is rapidly changing, and this thus does not satisfy the model cancer inclusion criteria. And finally, we have included some clarifications to help address questions from the stakeholders and future RO participants related to the interaction with the RO model and the quality payment program. Specifically, we listed, we did our best to try to explain through the track 1 and track 2 definitions that we proposed to explain what you need to do to be an advanced APM, what would have you be a MIPS APM, and which would have you be neither. So that was the intent of the proposals related to the track 1 and track 2. Next slide. So before we get to the question and answer session of this evening, I would like you to do the following if you haven't already done so. So first, for your organization, appoint a RO model lead, someone in your organization that knows and is keeping abreast of everything related to the model. And if you have a minute while I'm going through the rest of this slide, if you would like to type into the chat, if I called your facility or your location and wanted to talk to someone who knew about the radiation oncology model and could answer questions, if I had some for your organization, put in the chat what their title is, not their exact name, but is it the the practice administrator? Is it the facility administrator? Is it the head of billing? So if you could throw some of those things into the chat, I'd greatly appreciate it, because I do call locations on occasion, and we will be reaching out to locations that may not have contacted the help desk to do number 2 on the list there, which is obtain your RO model ID. So every participant of the model is assigned a model ID, and we need you to call the help desk and provide your TIN or tax ID number if you're a physician group practice or freestanding radiation therapy center. And if you're a hospital outpatient department, you would provide your CMS certification number, as we call it, the CCN. When you call to get your model ID, we need you to provide the first and last name of the primary point of contact and their email. And then once that's loaded into our administrative portal, we need that primary point of contact to register and log into the portal, which we call ROPE, which stands for the Radiation Oncology Administrative Portal. And then once the primary point of contact's in there, they can add lots of other points of contact. There's up that you can have 5 primary contacts, 5 secondary, and 5 legal contacts. But it's really, really important that they put a legal contact name and email in there, and then have that legal contact register for ROPE, because only the legal contacts can do the attestations. And if you're eligible to opt out of the model for the first year because you're new and you have low volume, only the legal contact will be able to check that box that you're testing that you want to opt out. So other things that you can do is
Marcy, if I may, sorry for the interruption here, just for clarification here. So that legal contact is that a designated institutional official, or is it when you say legal, is that as in counsel?
No, it's whoever you determine in your entity has the ability to speak on behalf of the organization and say, hey, yes, I want to opt out. We don't want it to be, I'm going to make up a title, a clerk who says, hey, I've heard bad things about this radiation oncology model. I don't think we should be in it. They shouldn't have the ability to opt out of the model. Sure. It's someone who can make a informed decision in the best interest of the practice.
Understood. Thank you.
Yeah. Okay. So when in ROPE, we'd also like you have the ability to update addresses, legal names, doing business names. We pulled all this information into ROPE that came from PACOS, and PACOS, people don't always update that when name changes occur and things like that. So if you log in and it looks like that's not the name of my practice, well, just go ahead and fix it in there. Okay. We pulled it from PACOS, and then you probably should go into PACOS and fix that too, while you're at it. And then again, see if you're eligible to opt out for performance year 1. That information is there right now. Excuse me. And then again, respond to calls or emails from the RO model team. We often we get emails or inquiries through the help desk, and it's not quite clear what the question is, and we try to reach back, and then we don't hear any response. So it may be that you need to add radiation therapy at cms.hhs.gov to your safe list or your contact list, so maybe they're going in your spam folder. I don't know, but please respond when we try to contact you, and continue to attend the webinars. We've had tons and tons of you guys on the webinars, well over 1,000 participants on each webinar. So that's great. Continue to access the resources on the RO model website, and that website address is on this slide. And again, don't hesitate to send questions to the help desk, either via email or via the calling with the phone number listed on this slide. Next slide. we're going to go move to the questions. So I guess I'm
Great.
giving it back to you, Dr. Heron.
Great. Thank you, Marcy. And thank you for that overview. We'll move into the pre-submitted questions. How will CMI determine whether EUC exists for a region or the nation to suspend implementation of the radiation oncology model? How is the process initiated since a participant cannot apply themselves?
Okay, hold on one second. I'm getting to my answers. I had them all prepared, so I didn't miss anything important. But that's a great question. We do have specific language in the proposed policy that indicates that the policy will be applied to local, regional, or national events and not to individual participants to help identify RO participants that are experiencing an extreme and uncontrollable circumstances. CMS would consider the following factors: whether the participants are furnishing services within a geographic area considered to be within an emergency area during an emergency period as defined in the 1135G of the Social Security Act. And all this is in the proposed rule. And whether the geographic area within a county, parish, U.S. territory, or tribal government designated under the Stafford Act served as a condition precedent for the Secretary's exercise of the waiver authority on a National Emergencies Act, and whether a state of emergency has been declared in the relevant geographic area. And if you want to notify the RO team of a local event that you fear we do not know about, please send to the help desk a detailed description of the situation, the extent of the situation, and how long you believe the effects of the event will last. That will be helpful for us to process and get back to you with what your status would be.
Excellent. And Marcy, can I ask sort of a follow-up question to that? I realize this is a bit of an impromptu. Is it the thought that once a designation is made, is it for a certain period of time within that year, or is it designed to be for the duration of the declaration or for the entire year? And if you don't have the clear answer for that, if you want to defer that to a written to a response later, we're happy to entertain that as well.
Yeah, I think we will explain that further in the final rule, but you know, that we need, it will vary on the different circumstances.
Okay, great.
You know, a localized flooding that may prevent you from submitting, you know, or there's no power or whatever, could be different than, you know, like what's going on in Louisiana, which has just been going on for well over a year with all the hurricanes that they just keep getting standby. So it will vary. So we will provide some more written response on that.
Okay. Excellent.
Another related question, Marcy, that we got, again, not pre-submitted, but, you know, another kind of on that topic was, again, don't expect you to have an answer, but you know, would folks kind of know by the final rule if, you know, here's kind of the map of the EUC regions? Would that be something that would be kind of available? And then, you know, would that map, if you will, kind of be updated over the course of the year with COVID, if there are areas that spike? You know, would that map kind of be updated to say, okay, here's another EUC region? So that's, again, not pre-submitted, but just another kind of round of questioning that we got kind of related to this item. So. Oh
yeah, thank you for that. That's a good way to think about it, whether it's in a map format or if it's, we say, okay, here's a list of, you know, since no one knows what their CBSA number is, and if you do, I'm pretty impressed, but is that we would say these zip codes are in a, you know, a geographic region that has been deemed to be an EUC, and we would say, okay, these zip codes. So whether it's a map or a list of zip codes to be determined, but the map idea is kind of cool. So thanks.
Okay.
Excellent. Next question. So this question relates to several scenarios, and I'll just read the first part of the question. Will the 28-day period for professional HCAPs to the technical HCPCS be applied based on the date of service or the date of the claim is received?
So everything in the model is based on the date of service. So we recognize, and I think there's another question about the timely billing and things, but it really is based off of the date of service. I think we did a really good job, if you haven't gone to the billing webinar yet, but to review that, that the start of the episode is commensurate with the day the treatment planning service is provided. So when you submit that start of episode claim with the RO model HCPCS code, say the one for breast cancer and the V1 modifier, that date of service would be the same as the treatment planning. And it doesn't matter if you submit it 3 months later or 9 months later, but we do encourage you to submit your claims timely. And most people do. I mean, even though people have like up to a year to submit claims, that's not what most people do according to the statistics in the claim system.
Excellent. Next question. Please confirm the no pay claims cannot be submitted until the SOE HCPCS claim has been paid by the MAC. This will require significant change in workflow for all participants, and if errors occur by the participants, there's a risk of overpayment.
Well, I gave this question a lot of thought, and if the person who is on, who asked this question is on and want to add something in the chat after I speak, that would be great. But technically, the way the system is programmed, they're going to look, if you submitted what would look like the traditional fee-for-service claim, which would be like our no pay claim first, the system's going to see that your site of service has a zip code in the model, and there's an ICD-10 code on there, and that there's an included RT service on the claim. They're going to return that claim to you and not pay it and say, hey, you need to bill, and however they word this, but this is my words, hey, you need to pay to bill the RO model way. There's a CARC or RARC that will tell you that you need to that you'll get it back. And so there's no way that we would be overpaying, like we wouldn't be paying that claim and then paying the start of episode claim. The system's not set up to do that. It's set up to prevent that, actually.
Okay, great. Thank you. Question 4. Currently, providers have a year, you kind of sort of started to address this a little bit, for timely billing of services provided to Medicare beneficiaries. Does this still exist for those in the model? And are they expected to bill the RO model services at the time the services are rendered? I think you sort of partially addressed it, really addressed this already. Yeah. Or is there a different timely filing deadline?
No, you can, as long as you're meeting Medicare's policy for, submitting all your claims within the year from the service or whatever, you can continue on your established billing cycle. If your office or your center only bills once a month, that's fine. Just, but to remember, this is a prospective payment system, so you can get paid day one before, a lot of services have been rendered. So that's going to be up to you guys on when you decide to bill, as long as it's within, the current Medicare guidelines.
Excellent. Thank you. Next question. The CMS 1500 claim allows for the use of pointers to direct which services are related to which ICD-10 diagnosis code. The UB04 claim used by hospitals do not allow for pointers to be used. Will the pointers from the professional claim only be used to direct when there are multiple diagnoses or cancer types treated at the same time?
Okay. So the claim systems have been programmed, and it's the way it is, today. We didn't change it for the RO model. Is that they look at all the ICD-10 codes on the claim. It doesn't matter in what position it is. So the claim system will first look to see if the service location address is located in a participating zip code. And then the system will look then for an included ICD-10 code associated with one of the included cancer types in any position on the claim. And if so, the system will expect an RO model specific HCPCS code and related information be included on the claim. We do know there'll be scenarios where there is, and I think if you look at slide 34, the billing webinar, there's a scenario depicted where you're treating, the patient has a history of an included cancer type, but you're currently treating a non-included cancer type. So say they have a history of breast cancer, and now they have melanoma, and you're treating the melanoma. And I'm just making stuff up right now, but that's not the example we used in the slide, but I forget which one we used. Because good billing practices have you put all the ICD-10 codes on there, when they see a code that's associated with an included cancer type, not they, but the system, it would expect to be billing the RO model way. So this is where we laid out different scenarios where you would use a modifier to get paid fee for service for that cancer type that you actually are treating with an included RT service. But again, I would encourage you to go back to the billing webinar to look in detail on that scenario.
Excellent. Thank you. Next question. If two areas are treated simultaneously, one in the model and one out, are the services such as a simulation or treatment delivery where both areas are simulated or treated in the same session? Is it correct to assume that the area under treatment in the model is billed per the M codes and the other is billed as fee for service?
So this is one where I kind of like throw the question back to you guys. Whoever asked the question, this is one of the times I would ask, a little bit more detail, but under current fee for service, would you be able to bill that same procedure twice? If you performed the procedure once, but it was for two different cancer types or two different tumor locations, would you be able to bill it twice? If you are, then I would say yeah, the answer is yes. If you would not have been able to do that under fee for service, you would not be able to do it and get paid for it twice under the RO model.
Yeah, I mean, I think we've got somebody on the phone that asked that question, so please feel free to clarify in the chat box, and we can loop back to you on that item. Great.
And I do have our provider billing group on standby to give a more clear answer when I get a little bit more detail from the person who had the question.
Excellent. Next. If brachytherapy services are excluded, there are several codes which are used to report services for brachytherapy, devices, simulation, and planning, which are also used for modalities part of the model. Is it correct to assume that exclusion of brachytherapy services is not just brachytherapy specific codes, but all codes related to brachytherapy modality or portions of planning and treatment?
It is correct to assume that, but there will be a billing procedure that you will need to do to make sure that happens. Again, the system has been programmed to look at included RT services, and if you're including it for included cancer type in an included zip code, they're going to expect to see those non-brachytherapy, but like the treatment simulation or whatever codes that maybe one that's also included in the model. They would see that and say, hey, why aren't you billing the RO model way? So we did have an example of this on slide 38 of the billing webinar, where we included an example claim where the codes for the treatment planning and treatment management include the GB modifier, and the brachytherapy specific codes do not. And these same rules would apply to other excluded modalities like IORT and any other neutron or whatever that's not included in the model. But since the RT services associated with the professional component are included RT services and subject to billing edits, then the professional and dual participants will need to apply that GB modifier to get paid fee for service for those services.
Okay, thank you. Next question. Will there be an opportunity for small physician shortage areas, shortage area rule of practices to opt out? So.
Yeah. At this time, there's no specific policy for the physician shortage area folks, but they may be eligible for the general opt-out policy. So I encourage you to log into the Radiation Oncology Administrative Portal, or ROPE, to see if you are eligible for Performance Year 1.
Okay, thank you. Next question.
Well, I think that's it. Dwight, we did, though, get a clarification on that question 6 in the chat. You want me to read that off?
Sure. Here, I'm going to have to go over and expand that chat box here. So the value of the simulation is included in the reimbursement for the model. Included area for the separate area has a code that could be billed. Wondering if this is double dipping because the code is billed fee for service, but there is a value represented by the model cancer.
And she's
So
saying
this was for not this one is question 5.
Yep.
Yeah, this is for question 5. This one, correct?
I think it's question 6, but that's okay.
Oh.
But I still think the question is, what did you do prior to the model? Like, what would you do today if you were in this scenario? Would you put that CPT code or HCPCS code for the treatment planning on the claim twice with the data service, same data service, because you're doing it for a brain tumor and an ocular or a lung tumor at the same time? So that's where the double dipping question comes into play. And like I said, I wanted to know, because I wasn't able to connect with the provider billing group people to get this, but if it would be considered double dipping under fee for service, it would be considered double dipping under the model. So we will get back to you with very specific info on that.
Okay, great. Thank you. We did have a question in the chat. Would participants in an area declared as a EUC expected to start after January 2022? And if so, would they still qualify for the 5% APM bonus?
That's a good question. That's I think it depends on the scenario. If you were not participating at all in 2022, you obviously wouldn't be eligible for it for the APM bonus. And we do know that for existing models that you would still get that, but because this model hasn't started yet and you haven't started yet, we're looking to see how that will be handled. The QPP folks have to opine on that for us.
Okay.
And you got to remember, the RO model doesn't make the QPP rules. We just try to explain them to the RO participants. So we have been asking, we have asked this question in anticipation of you asking this question.
Excellent. All right. I think those are the questions that we've had in the chat and that were pre-submitted. Are there any other questions from the members? put it in chat.
Now's definitely the time to ask.
I'm looking at, there was an additional question that you sent me. Oh, it was about, we've got this question a couple times now, is that some of the technical services related to treatment planning might get billed the day before the actual treatment planning session is billed by the physician. So like, so what would they be included, and which one is the one that actually starts the episode? But it is the treatment planning codes, the 77261 through 63, that are the treatment planning code that would start the episode. But we are relying on you guys to say, because you don't put those codes on the start of episode claim with the RO model HCPCS code, you're putting the M code for breast cancer, start of PC or TC on the claim, or both on the claim if you're freestanding, with the V1 modifier. And that date on there should correspond with the treatment planning code. But when you submit your no pay claims, you're not gonna get in trouble if, like, the example in here where some of the devices were ordered the day before or whatever. We'll recognize that sometimes that happens the day before or whatever. But it'll be on the no pay claim. You would not pay, bill fee for service for those. If you billed fee for service for those with a date claim with a date of service prior to the start of the episode, there would not be an episode, because we look and see that there's no services in the last 28 days. If there were services that were included, RT services in the last 28 days, then you would not be able to start an episode. I hope that makes sense. But I'm going to take this one. I think this is we've started an FAQ that's similar to this, but I'm going to take some of the nuances of this question and add it to our FAQs.
Oh, great. Good. Oh,
so
yeah.
I think is there a Sheila, is that a question that you want us to ask?
Yes, please.
Okay, so Marcy, the question is, in terms of reporting back on the model and performance, AKA savings, patient outcomes, are there plans on reports back? And if so, are there yearly reports? What's the cadence? How are reports reflected? And I'm going to extend that, perhaps, is that is reports perhaps back to the individual practices. And obviously, are there plans for CMS and CMMI to report on some basis to the radiation oncology, either model participants or community in large, and on those findings, those metrics?
Yes, so the plan is there will be quarterly performance feedback reports for the participants that will include their participant specific information. And then we're working currently on a web-based dashboard that will be dynamic, and they can like slice and dice that, where like when you get a PDF of a report, you can't really see the background of it. We're working on a dynamic report, so you guys would be able to click on a specific metric and see how we came up with the summarized metric result. And so that will be quarterly. And then obviously you guys, some of you are familiar with the oncology care model. So that there's CMMI models, there are annual reports that come out that kind of have a overarching like summary of how things are going. So that will be happening too.
Okay, excellent. Thank you. I think do we have another? question here?
We do.
Yes, we have a couple more. For very large group practices that cover multiple zip codes, but are under one single tax ID, how will they be handled for reporting?
For reporting, it will be, so we do have FAQs very specific to this in our FAQs. So make sure you go back and look, because I'm talking off the top of my head right now and not have them pull up. But they will, so if you're a TIN and you have multiple locations, and some of your locations furnish services in an included zip code and some do not. So let's say if you're a professional or dual participant, that's required to submit quality measures and clinical data elements, you would submit those for the beneficiaries that are receiving services in just those service locations that are included in the model. And so if Dr. Smith, you have 20 doctors, but there's 5 of them that are in that for furnished services in an included zip code, then they would need to be included on the individual practitioner list that's in ROPE, so that you guys get credit for those doctors for the QPP purposes. So we'll be submitting that. So, but you would not submit quality measures for patients that are not being serviced in one of the included zip codes. And the other question, just in case you are part of a multi-specialty practice, it is only patients treated by a radiation oncologist that would be included in your reporting.
Okay.
But again, we do have all this information in FAQs and in the quality reporting guideline or guide that's on the website.
Okay. Any other questions? These are great questions, by the way, and I appreciate the participation, Marcy. I appreciate it. This is a complex program, and I know there are lots of questions that have been asked over the last year or so, and asking you to remember some of the finer details is challenging. I appreciate you taking a stab at those. But as Marcy said, please, there's an FAQ that you can go back and take a look at on the website. So do that as well. And there's some, we've certainly posted our last webinar on the membership portal of the ACRO website. So just reminding our members to go ahead and take a look at that as well. Any other questions?
And
Okay.
and honestly, send them to the web to the help desk, and we'll it might be, even if it's very practice specific, that's okay. We know that there are scenarios that are unique in the business arrangements in radiation oncology, and we've actually had calls with folks to kind of make sure everybody was understanding what the scenario was and stuff. So submit those through the help desk. And then if it's a general question that like applies to everybody, those are the types of things that get added to the FAQs. So don't be afraid to ask the question, because you're probably not the first one to ask the question. But you might be the first one, but you won't be the last one.
So I know this has probably been asked in the FAQ, or certainly asked before. I know there's some version of this, but there are some small practices, some practices that are serving underserved communities that may have challenges in putting together their information systems to be able to submit the claims and in the model, because again, they won't just be seeing patients who are Medicare patients, but they also obviously see third-party payers. Are there what are the options for those centers that may have difficulty in submitting those claims come January 1st, 2022, and how would you suggest they interface with either the portal or with your team to help get them there? Because I think we've heard before and that there are sites that are already now having trouble figuring out how they're going to submit their claims differentially from what they normally would do.
Oh, okay. So I thought you saw, okay, so we're talking claims, not like quality measures and.
Yes, that's
okay.
correct.
Okay, when you started that question, my mind immediately went to quality measures.
Well, we can talk about that too, but let's do the claim side of things.
I don't think I can answer that off the top of my head on the best way to do that.
Okay.
But I will say that we replicated the way you bill claims today. Or not, not just you, but, we replicated the way OPPS and the physician fee schedule payment systems, and they are two different systems. A lot of people think all the Medicare claim system is one big system, but there's like 47 different claim systems out there. But we did replicate the current process as much as possible. So with the exception, you would, like the normal fee for service that you're doing now would be the what would become our no pay claims. The difference is that start of episode and end of episode claim that just has the RO model specific HCPCS codes on it. And I don't know, it's a good question, and if you guys will send that to me, if you didn't already,
Sure.
We'll get you some better information, because
Yeah.
there are so many billing,
Yeah.
systems and not, out there and resources out there. I don't want to just pigeonhole one answer and make people think that's the only way to do it.
I appreciate that. And I think, Jason, in that question, the reason why there's a bit of difference, even though they mimic perhaps our existing fee-for-service systems as they exist now, on the back end of things, since we're looking at episodes, not infrequently we'll have patients who were treated for something, and then within that, what we would call now that episode, they may be treated again for perhaps a different site, and that would have been billed separately. But now, if it's an included diagnosis in the model, it will still come under now a fee for come under the model and not be billed. Mm-hmm. So those are the nuances that we're hearing, and so maybe if we can have a little bit of discussion and then a response around that would help. We do have another question, and I know we're getting close to the time limit here, but would you comment on the exclusion criteria for protons under the model? We believe protons are excluded in patients who are enrolled on federally funded multi-organizational, multi-institutional randomized controlled trials. So can you comment a little bit further? Is that the only criteria in which that's the case, or I'll just leave it at that?
Yeah, yes, it is the criteria to be able to be paid fee for service is that they are participating in that. We get a lot of questions. Can a retrospective registry count and things like that? And we've talked to a lot of people in making this decision. It wasn't, the radiation oncologists from different institutions and folks that, know about clinical trials and Medicare billing and things like that. So that's where we landed on that very concrete guideline for what would be billed fee for service.
So bottom line is your protons excluded only if the patient's enrolled on a it's federally funded. Could it be So it has to be a federally funded, multi-institutional prospective study. Is that the
Yeah.
only? Okay.
Yep. I was trying to pull up something that I could pull the exact language real quick, but you beat me to it.
Okay, got you. All right. Well, I think we have a few more minutes. If we don't see any other questions, we'll wrap this webinar up. Marcy, this has just been absolutely amazing. I think it's really been very helpful. Again, we can continue to appreciate your continued commitment to educating the radiation oncology community, certainly our membership, and we look forward to our continued engagements, and we'll send over those other additional questions as they come up as well.
And I just want to remind you guys, the comment period for the rule ends Friday
Right.
at 5 o'clock. So send your comments in. I don't think I've seen your guys yet, but
it's coming. It's
okay.
coming.
I'm sure it is, but I've had my eye out for it.
All right. Thank you. All right. Thanks, everyone. Have a great evening.
All right.
Thank you very much.
Thanks. Bye-bye.
Bye-bye.